To welcome you to our fifth meeting for the Aliso Canyon Disaster Health Research Study. My name is Mike Jarrett. I'm a professor of environmental health science at UCLA, and I'm the Jonathan Fielding Chair in Climate Change and Public Health. I've been doing air pollution, health effects, and exposure work for about 25 years now. And I was one of the few independent investigators who was in the field doing measurements during the disaster event in 2015 and 2016. What we're trying to do with this meeting is to give you updates on where we're at with our study. We have a lot of results to present tonight. We've got really, I think, some very interesting results on healthcare utilization during the event that Dr. Natty Pratt is going to present. And then Dr. Mike Kleeman has just driven in from UC Davis, who's going to present our chemical transport modeling, which I'll tell you a little bit more about. So we'll be looking first at the emergency room visit analysis, and then secondly at the chemical transport modeling. What we're trying to do here is give you preliminary results and to get your feedback to see if you think we need to go in other directions or cover other topics. And we want to make sure that the community is the first to be informed of any of the results so that you don't read about this in the newspaper. We certainly invite your input, and we've appreciated all of the careful and thoughtful input we've gotten from you so far. And following our preliminary presentations, I'm going to give you an overarching update on where we're at with the study and what's on schedule, what isn't, what's ahead of schedule. And then we'll open it up for questions, and we'll stay as long as you'd like to keep asking questions. We're happy to stay here and answer them. So I'd like to now turn it over to Ms. Lisa Ballin, who is going to be our facilitator for this evening. Thank you, Lisa.
Thanks, Dr. Jarrett. Is this okay, or should I use this? Okay, okay, super. Thanks again. Thank you, everybody, for coming and welcome. My name is Lisa Ballin. I'm a facilitator with Sacramento State University. However, I live locally. My job here tonight is to just guide us through our agenda and our discussion. As Dr. Jarrett mentioned, we have a lot of material to get through to discuss tonight. What we'd like to do is to complete each presentation and then open it up for questions and discussions. So if you're in the room and you think of a question during the presentation, feel free to just jot down a little note. You could use some of the papers that we've handed out this evening. For those of you who joined us online, feel free to enter your question in the Q&A box, but just know that we're going to wait until the presentation ends before we address those. And once we do finish the presentation, I'll alternate between questions in the room and questions online. If you'd like to make a question verbally, I'll ask you to raise your hand and I'll keep a queue. If you're more comfortable having me read your question, you can use the comment card that was in the packet. Just feel free to fill it out and hand it to me and I'll read it for you. We also have a comment form if you just prefer to leave us a note that we can look at after the meeting, and that's this form here. Okay. Super. So just to respect everybody's time, we said the meeting is from 6 to 7:30. So I will try to get us through the full agenda by 7:30. But if there are more questions that we didn't get to, as Dr. Jarrett mentioned, we'll continue after 7:30 and take all the additional questions that we didn't get to. Okay, and for anybody here who's new to the study, and it's really nice to see familiar faces and a bunch of new faces as well, so welcome. If you weren't able to attend the prior meetings or not as familiar with the study, please take a look at the website. There's a lot of information on that website, and the information sheet that you got does have the website link, and we'll put that, this sheet here has the website. And we'll put the link in the chat for those of you who are online. Each of the meetings is recorded, and the first meeting recording provides a nice overview of the whole study. So that could be helpful. Let's see. Next slide. Okay, that worked. Just a few notes about the online features for anyone who's new to Zoom. If you need to access the Q&A box, you can just click on the Q&A icon that's at the bottom of your screen. And if you see that you have the same question that somebody else asked, please just upvote that and we'll make sure to get to those questions. And to raise your hand virtually, sometimes it's a little tricky. You have to first click on the reactions icon and then you'll see the raised hand feature. The chat feature is only going to be used for us to send out information such as the links. And as just so everybody knows, it's probably obvious, this meeting is being recorded. It'll be posted on the study website and on YouTube. We are aiming to avoid recording any of the participants, but as an extra precaution, if you're making oral comments and you're on Zoom, please turn off your video. We'll also be posting the PowerPoint presentation on the website, so you'll have access to that. Just a few quick meeting guidelines just to make sure we continue to have the productive conversations. I'm not going to take our time to read these. And with that, I would like to turn it over to Dr. Hong-Hu Liu to introduce our first presentation. This is the events.
Thanks, Lisa. Hi, good evening, everyone. It's so nice seeing everyone here in this room this evening. I'm Hong-Hu Liu, professor and the chair of Public and Population Health Program at the UCLA. As you know, our study team has been working on different analyses of exposure and health and the impact on health from multiple aspects, such as the birth outcome analysis we presented before. In the past number of months, our team has been gathering data from California Department of Healthcare and Information, known as HCI, and doing analysis to see whether the blowout, which happened 2015-16, actually resulted in increased rates of healthcare utilization. Now, as an indication of some significant acute events experienced by the residents of the impact zone. So we have been conducting analysis, actually going through more than 60 million of the emergency department visits record. Now I'd like to introduce Dr. Nadi Parade, who is our director of administrative core and the lead of healthcare utilization analysis, to present the findings of the emergency department visits.
Thank you, Dr. Liu. Good evening, welcome. Thank you for joining us for the presentations tonight. I'm Nadi Porad, as I was just introduced. I'm a professor in health policy and management at the Fielding School of Public Health. I'm a director, associate director at UCLA Center for Health Policy Research, and I direct a program called Health Economics and Evaluation Research Program. I have over 20 years of experience analyzing healthcare utilization data as a method of understanding outcomes. As you can not see yet. Okay. These are the other co-authors of this study. I'd like to acknowledge them. And as also was previously explained, all of the analysis that we present to you tonight are preliminary in the sense that they have not been published. They're subject to peer review. Therefore, some things might change. So why study emergency department visits? Literature has indicated that exposure to hazardous air pollutions that are found in natural gas are associated with impacts or risks for certain bodily systems, including immune system, nervous system, respiratory, dermal, gastrointestinal, etc. We also have information from the residents that have told us about the conditions they have experienced. The CASPAR data that you're aware of also indicated the kind of symptoms that people reported during the exposure. However, the actual scientific evidence that links the exposure to outcomes is lagging. So that's what the gap that we were trying to fill with the analysis. The ED visits are actually a good source of information, and they help us to examine health impacts of exposure on the individuals that live in the area. So our premise is that people who were exposed to the air pollutants that were released during the blowout would seek care from emergency department visits if their symptoms were severe and urgent. We, of course, understand that people might have gone to their primary care doctors for their symptoms. Most likely, if those symptoms were milder, and or if they perceived less urgency, or they were able to get appointments on a timely basis. So the question that we ask is, did the impact zone residents experience adverse health outcomes? And we are looking at the impact on overall emergency department visits, and we are also looking at impact for specific conditions and symptoms. And so I'm going to explain the approach to you. So the data sources that we're using, as explained earlier by Dr. Liu, include the data from California Department of Healthcare Access and Information. The advantage of this data source is that every emergency department in the state must report their emergency department visits to the state. So it's the universe of all visits. So it's comprehensive, it's not missing visits. It is also reported annually, so we do have all of that information available. For this analysis, we're looking at 2014 through to 2017. That's the data that we have currently available. One important piece of information about this data is that it is reported at the zip code level only. This is for confidentiality reasons. So we understand that some people that were relocated might have had a different address. We expect that most people were reporting their permanent address, but it's an assumption on our part. So then the other piece of information that we needed for our analysis was population estimates in each area. That's because we want to compare the estimates between two different areas, and we needed to make sure that we're comparing apples to apples. So if a population is bigger in one area, the number of emergency room visits are higher, but that's not comparable. So we created a ratio or a rate. So one of the things that we're analyzing, as I indicated already, is the overall number of ED visits. So we're looking at ED visits per 1,000 residents in each of the two communities. The emergency department visits are actually quite rich in the kind of reasons or the diagnoses that patients presented with. But there's also, so most of the time, if an individual goes to the emergency department visit, and if they already have conditions, it is much more likely that that condition gets listed as the primary reason for the visit. So if someone has asthma, goes to the ED, they're having breathing difficulties, asthma gets recorded. So that's what you'll see. However, if somebody does not have pre-existing conditions, and they go to the ED and they report, let's say, breathing difficulties, but they don't have asthma or other types of conditions, that is not likely to be recorded if the ED physician cannot make a diagnosis with the information that's available to them. So as you know, typically ED cannot do the full diagnostic of the kind of things that might happen on the outpatient side. So therefore, we were able to use this information to look at ED visits for specific conditions. So these are conditions that are on the record. And the categories of conditions that we looked at are listed here. This is what we use the literature to identify these conditions. We break up respiratory conditions into acute and chronic conditions, particularly because of the fact that the time period where the blowout happened overlapped with the season for acute respiratory conditions. We also examined sorry, I'm out of sync with my presentation. We also examined ED visits for symptoms that are associated with specific categories of disease. So breathing abnormalities are associated with breathing conditions. So we also look at those. And these are broad categories of disease. In order to get a little bit more specific, we also looked at specific conditions that were reported in CASPAR, specific symptoms that were reported in CASPAR by the community. So we wanted to also validate some of the reporting in that data. We wanted to see, do we see a signal in the emergency department visits for those specific conditions? So we next identified the impact zone and the comparison communities. This should be familiar to you from meeting 2 when we actually explained how these 2 areas were selected. So you probably remember these census tracts that were selected. These were selected by our team based on available environmental information and population characteristic information, with the goal of identifying a community that's not exposed but is similar as possible to the impact zone. So if you take out those census tracts, you'll see the broader area that is studied. And then because, as I explained, we only had zip codes, we could only select zip codes. And when you overlap the zip codes with the areas, the census tracts, you'll see that for both of the red is, let me point to it for a little bit more clarity. So you could see this is the impact zone, the red area. There, the actual 5-mile radius is slightly smaller than the zip codes that we have selected. But as you probably know, some of these areas have very low population density. The same thing with the comparison community. Some of the areas that we had to include because of the zip code issue are also very low population density, particularly here in the coastal area. So this is what we actually are looking at. So the next thing that we needed to consider was, well, what time periods are we going to look at? The important consideration here was that there is seasonality in ED visits. if you look at patterns of ED visits over time, you'll see there are certain times a year, there's a lot more visits than other times of the year. So we had to consider that. We also had to consider that we have the flu season overlapping with the blowout period. So what we did is we then decided to look at the time period of October 2015 to April 2016. It is a 7-month time period, and that's the duration, that's the time during the blowout. We then identified a similar time period in the year before and a similar time period in the year after. We wanted to see whether the patterns changed from before to during and from during to after. As you can see here, the observation period is actually extended by 2 months. We went 2 months over for a couple of reasons. One is that we wanted to capture that entire flu period because we do need to discount the fact that that this is overlapping in time period where people may go to the emergency room more for acute conditions, acute respiratory conditions. We also know in the CASPAR data that people reported going to the seeking care even after the blowout period ended. So we wanted to capture that entire time frame. We did some analysis to restrict the time period to when the well was, when the blowout ended. And the results are quite similar. There's just fewer ED visits to capture in that time period. So the other thing that we had to account for is that the residents of the two communities have differences in their characteristics. Because we're looking at the kind of data that we're looking at is not very rich. What we do have available is the following characteristics you see here. We have individuals' age, gender, race, ethnicity, preferred language for communication. We also have the payer. As you could imagine, insurance matters in what people do, because if you have high copays or the type of insurance that might restrict your ED visits, we have to account for those potential differences. So the analysis that we conducted is called difference in difference analysis. That's the methodology that we used. It's also called a quasi-experimental design. It is the most robust method of analysis after clinical trials, which are experiments, right? We compared then the rates of ED visits in the impact zone comparison community to see whether it changed before to during the blowout, and then also from during to after the blowout. So what did we find? I'm showing here the patterns of ED visits per 1,000 residents for the year, per year or per observation in the before observation period. What you can see here is this upper line that's in red is the monthly trend before the blowout in the impact zone, and the green line that you can see very closely following that is the comparison community. One of the requirements of our analysis that these two patterns are similar. And as you can see, we are observing they are similar. We next wanted to know whether the actual rate of ED visits in these two areas is different or similar to the broader areas where these two zip codes are located. So Los Angeles County and Ventura County, and those are these dotted lines up here. The lower one, the green one, is Ventura County, and a little bit further up is Los Angeles County. You can see generally these lower number of visits per 1,000 residents in our observation areas. We also looked at California overall, just as a proof of concept, understanding exactly what we're looking at here. Next, we then looked at the monthly trends from before, which I showed you a moment ago, to during. And this is what you see when you look at those. These trends are now accounting for population differences. Okay, so you can see this lower bar is what's observed in the comparison community. It is somewhat at about the same level as the period before versus the during the blowout period. However, the trend that you see for the impact zone is quite different. So there is a higher rate of ED visit in the impact zone. If you didn't have, if you didn't consider the blowout, what we might have expected would have been this yellow dotted line. So in the absence of the blowout, we expected to see this pattern. Instead, we see the other pattern. The expected is what we, how would you describe that? What we would have observed if the blowout would not have happened. Can we hold the, we'll get into it, yeah. Yes, so let's wait to do that. It is rather technical, so I'll explain that in, yeah. Absolutely, be happy to get into the weeds. Okay, so so these were monthly, a look at the monthly visits. The other thing that I wanted to point out to you, the spike that you see here is February 2016. This was the peak of the flu season that year. Okay. Okay, so the next analysis that we did is look at the average number of ED visits for that 7-month time period. And the process of the analysis follows. First, we looked at what happened, what was the average rate of ED visit in the before time period in the impact zone. And then we looked at what was the average during the impact zone. You can see the difference between these two. That difference is 30 ED visits per 1,000 residents. And then we did the same analysis for the comparison community. In the comparison community, the difference was only 4 more visits. That difference was not significant, so about the same, okay? Next, we do the difference in difference analysis, which you essentially measure the difference between this number and this number here, and you see that there are 26 more ED visits in the impact zone during the blowout compared to the comparison community per 1,000 residents. Not right now. 26 more, it's comparable. I can provide that later. Okay, so next we did similar analysis, compared what happened during and after the blowout. Now you can see the trends seem to change. During the blowout, this was the pattern we just looked at. After the blowout, you can see this is the observed in the impact zone that actually that trend flattens out, but is actually still higher than what's observed in the comparison community. And what we would have expected in the absence of the blowout is the same. So we did the difference in difference analysis again. You look at the impact zone, no significant change between the during and after periods. In other words, the rate of ED visits remains elevated the year following the blowout. And the same for the comparison community, their rates don't change, stays about the same. When we do the difference in difference analysis, there is no change between in those patterns between the two areas. We then do the analysis for specific conditions, for broad categories of symptoms, and for the very specific symptoms that the community had reported in CASPAR. As you can see here, these are only the significant differences that are reported here. All the other analysis I'm not showing because the differences were not significant. So what we found is that the rate of acute respiratory infection actually was elevated from before to during the blowout by, can't see the number here, by about 3.4 visits. For chronic respiratory conditions, we don't see an increase that's significant, though it is positive. And then we see an actual decline in the period after. That's the only time we actually that one, and then another time we have some declines. Anxiety and stress-related disorders, we see an increase in the number of ED visits for those reasons. Respiratory symptoms, for gastrointestinal symptoms, and when we look a little bit more at detailed specific symptoms, the respiratory complaints, these are things like cough, those are elevated. People were going to the ED for those reasons. We also see abdominal pain. Abdominal pain was not reported in CASPAR, but we were trying to understand why so many people were going to the for gastrointestinal symptoms, and mostly it was because of abdominal pain. And as you can see, this is one of the few where the rate goes up significantly from before to during, and it drops somewhat for the year after. Okay, so what are the preliminary conclusions that we have drawn from these analyses? There were more ED visits during and after the blowout in the impact zone. And to us, that implies that there was likely to be an exacerbations of pre-existing conditions for the people living in the impact zone. That's what was driving them to the emergency room. There was also a moderate to severe reaction to exposure for people that did not present with pre-existing conditions. The reasons for more ED visits during and after the blowout in the impact zone are consistent with exposure to hazardous air pollutants in natural gas. And they confirm that some of the symptoms that were reported by the residents in the impact zone community area were urgent and severe. There are limitations to the data. We could not measure repeated ED visits from the same person. There's not enough information, accurate information data to follow that kind of analysis, to conduct that kind of analysis. We could not measure visits to doctors in this data because we were only looking at the ED visits. It's by itself, it's not linked to anything else. And we could not measure health status directly. So what we're trying to do next is to address some of these limitations. We are trying to look at the UCLA Health data that allows us to look at outpatient visits. So that hopefully allows us to look not only at primary care visits, but visits to specialists. We're trying to do those analysis. We are looking at hospitalization data to see whether we see any increase in hospitalizations during the blowout. The same kind of analysis, we can see whether there's any signal in that data. And we're also going to see whether the results that we have, this analysis we've done here, also are consistent if we chose different comparison areas. So I'll end here.
Try to be on the run. So thank you, Dr. Perrette. So we'd love to open it up for questions. If anybody in the room wants to make a question, I'm going to see if this works here. And I need both hands. Can you please raise your hand and I'll just write your name down and make a cue. Yeah. Julie, and then David. Lynn, Greg, Matt. Lisa. Julie, let's see, are we gonna hand mics out? Okay, you first. Julie, right here.
All right. Can you hear me okay?
My blocking is-
Hello? Yes.
Yes.
Okay. I actually have three questions, but two are related. Right after the blowout, and if someone will remember the name of the doctor that was very involved, which he has not been involved in any of the studies afterwards for Nordella. And I know there were a lot of things going on, et cetera. I'm not going to go into details about it. But there was a lab locally in the valley on Balboa Boulevard where many of us went and got blood work done at the time. I can't remember the name of it, but there must have been thousands of us that went, and I mean, I had it done. I was wondering whether or not you had that information or were aware of that. It was right after the blowout. How many in here had their blood work done? I'm just curious. Well,
Was that the orthopedic place? where he was admitted?
on Balboa Boulevard, that's all I can remember, you know, maybe south of Devonshire or something. Okay, well, all I'm saying is if you can, I don't know how to give you more information. It's just that we all went and had blood work done at that time. The question that I have is, and the types of things that you were looking at, gastrointestinal, whether it was respiratory, I don't see anything on there about any changes in blood work. Was there a change significantly between, say, before the blowout, after the blowout, or this many years later? Are people finding out they have leukemia, lymphoma, they're, you know, et cetera, et cetera? I have no clue, okay? And just the last point I wanted to make, although I'm not sure it's significant looking at the statistics, the community that you used as the comparison community, which would be Simi Valley, Ventura County, and so forth. The Santa Susana Field Lab is right in that area, and there is right now, they have a meeting going on tonight. I couldn't split myself in half, so I came here, but there's going to be a massive cleanup going on very, very soon, and there is tremendous hazardous chemicals, radioactive nuclides, probably had some impact on people in the area, certainly within 2 miles of the lab. When you use that same area, does it make any change or difference in your statistics?
Thank you. I think Dr. Jared probably is the best person to answer your question about Dr. Nordella's report and all of the lab tests. I just say that this is only one of the analysis that we're doing. The number of analysis that we have planned are much broader, and we are looking at multiple data sources. We are looking at Quest data that's available to us. There's going to be a resident health survey and the health assessment that's going to also collect information. So there are multiple sources, but more specifically, Dr. Jared?
I am familiar with the work that Dr. Nordella did, and during the event, I had many conversations with him. He described it as chemically induced bronchitis type symptoms, and he was seeing a lot of that. We haven't obtained the specific test from that lab for the period, but we have obtained from Quest Diagnostics all lab tests that were done in the Porter Ranch zip code, and then several comparison zip codes. Those were chosen by the county, and we obtained the data post hoc. The control areas are not exactly the same as what we have, but what we're doing is linking those data to Dr. Kleeman's modeling, which we'll see in a minute, is very detailed and specific about the types of contaminants that could come from the Aliso Canyon facility during the blowout and on a routine basis. And we're trying to see whether or not we can find signals when we compare those comparison areas to the area that's directly affected by the blowout. So we're aware that this is one we're trying to build a broader base of evidence. And so far on the health analysis, we've done the birth outcomes. We've done the emergency room visits. We've done focus groups about mental health impacts. And we're moving into the blood test. And on the updates, I'll tell you about some of the ongoing clinical exams we're going to start implementing later this year. And then so the blood work, the lab analysis, we had one other question, I think. Oh, Santa Susana Field Lab. All of our analysis, and this was based on advice from the community, that we should exclude areas that were within a 2-mile radius of the Santa Susana Field Lab. So none of our control area intersects with the immediate surroundings of that. And we did have Deborah Glick, one of our colleagues, was very closely involved in a health study of the Santa Susana Field Lab. And she said that most of the evidence they had came within 2 miles. So we chose that as our comparison area. The good thing about this analysis, though, is that we could use other comparison groups. We could use places across LA County. People have expressed concern that they don't want us to look at areas that are adjacent to other oil and gas facilities. So we have a big array on the birth outcome analysis. Because we had the actual home address, we were able to look at many different control areas. I suspect these results are robust enough that they're going to definitely hold up to different control areas. And maybe if I could just go back to Craig Glanz's comment or question, these models are, what we're trying to do is mimic something that looks like a clinical trial where we have a treatment where, normally that treatment is a drug. And somebody takes a placebo and somebody takes the actual drug, and you compare whether or not the drug's effective. Because this is a natural experiment, we can't control the exposure to that impact as tightly. But what we've done is used a lot of remote sensing data, the chemical transport modeling, so that we're then able to look at that impact zone. And we base it on the the key assumption of these models is that the 2 areas are going to follow parallel trends over time. So, and we could see that was certainly the case before the blowout. Slight differences in the rates, but very similar patterns. And if we get the parallel trends, then we use the group that's in the control area to simulate what would have been in the impact zone in the absence of the event. Because we can't get that, we could never observe the full outcome of having the placebo, delivered to some people in one area or not. So this is the closest you can come, and it's sort of they're called quasi-experimental designs or natural experiments. So, there's a lot of heavy-duty math that underlies how to generate it's so-called counterfactual. So what would have been in the absence of the event? But the basic essence is that we're using that control group to simulate the trends. So there could be slight differences in the rates, and that'll be reflected because you can see in Dr. Pratt's slides, if we go back, that the shape is very similar to the control group. Well, yeah, so let's. Okay, yeah, so I just I didn't want to let that hang out
Yeah,
there.
thanks. And we do have a lot of people with questions, so if we need to go into that in more detail, we can maybe get to that at the end. But also, you're on the list as well. Meeting 3 also had a presentation that explained the difference approach. So just another resource for understanding that it's hard to understand. I'm going to go to a question that we got online that said I'd alternate. So the question is, can you please go over why you're unable to measure data with the same person? Also, what type of sample? Is this a random sample or a population sample? And I think the commenter is referring to the data limitations.
As I explained, this is the universe of ED visits in the state of California. So it's not a sample at all. It's everyone. It's everything. Any ED visit, anyone went to an emergency department, that is reported in this data. So it's not a sample. And the reason we are not able to report the individual level is because the data does have a unique ID. So these are visit level data. I hope that makes sense. So every line of observation in the data is a visit. So you have to have a unique ID identifier to be able to see who made that visit. There are less than 70% of visits in that data set have a unique identifier so that we could, so some people did not report their social security when they went to the ED, and therefore we cannot identify them. It was a big enough limitation that we decided that for the time being, we're not trying to track people in that data set. So that's the reason.
Thanks. We have David up next for the question. Oh, we need a mic. You want to just, we're going to be sharing mics tonight.
So I live in Chatsworth. I was part of the Aliso Canyon research study. Okay, my name is David. I was part of the Aliso Canyon research study. I live in Chatsworth, not in the immediate Porter Ranch area, but my concerns are a couple things. First of all, my daughter went to Porter Ranch Community Middle School. There were over 90 nosebleeds reported to the nurse. So while it's admirable that you talk about ED visits, the full context can't be completed without talking about what happened to the kids at Porter Ranch. And second of all, I'd like to express a concern that while ED visits are a really good source, I talked to at least two people, including my ex-wife and daughter, who had to relocate to Ventura Boulevard. They didn't want to be they didn't volunteer to be part of the study. And I had another neighbor who didn't also get contacted. So my concern is that the people directly in the impacted zone were not contacted. Without them volunteering, you wouldn't have a complete scope of the whole issue. So maybe someone can address those two things. And I had a third thing too, but that long-term study. So we've talked about the 3 or 4 up to year 20, 10 years maybe, but birth defects, long-term health problems, is that going to be addressed? Thank you.
Thank you. Thank you for the questions. We actually did look at nosebleeds as a reason for going to the ED. The numbers are very small. The analysis was not significant. So the number of people that actually went to the ED with a nosebleed in the day, it was not that as large enough. I understand. Thank you. I appreciate what you're saying about the children experiencing it and then it's observed at the school, but it is not in the data that we're looking at. We did acknowledge at the beginning that we definitely know this data has limitation. I think we are looking at multiple data sources because we believe we can learn different things from each one. Each one provides a piece of the puzzle. None of them is providing the full picture alone. So more analysis are planned to look at doctor visits. I don't believe so far we have analysis to get data from schools, but thank you for making that comment and helping us think about those kind of issues. In terms of volunteering, the ED visit data that we're looking at is reported by the hospitals. It's regardless of, nobody has to give their consent for this information. We have all of the data. It's blinded to us by who the individual is. So confidentiality is preserved. But if you did go to the ED, your information is in there, whether or not anybody asked you would you allow it? It's just the nature of this data. In terms of long-term impacts, you're absolutely right. What we're looking at is really, because it's also the ED, by definition, it's a short-term acute impact, right? It's what people experienced at the time, during that time period where they were being exposed. Some people moved away, but they were exposed before they knew what's going on. The people came back. We think that some people came back and maybe there was still some pollutants in whether it was their homes or the air, in the air or on surfaces, there was still exposure. That's why we extended the period we're looking at. You're absolutely right. Short-term impact, we have analysis of long-term impacts. So the birth outcomes data that was reported in 2 community meetings ago, that was one of the studies, and there's more planned.
That I'm hearing is, you're understandably very concerned about the children's health. And we could do sub-analyses from the emergency room visits that just look at pediatric cases to see whether or not they followed the same pattern. I don't know if it has to be a pretty severe nosebleed for somebody to go to the emergency department. So there's something called the epidemiological pyramid. And I don't want to get too geeked out on you, but at the very top of that pyramid is death. And then the next level would be something like severe atherosclerosis, diabetes, serious chronic diseases. And then the next level would be hospital admissions. And you go down to get to something where it would be nosebleeds, symptoms that are affecting broader populations, but they're also not as well reported or consistently reported. So I don't think we have a good source of those data. We could go and check with the schools, but I've tried that in many other places, and they don't keep very good records, right? The school nurses are, they're very action oriented to help the children. Yeah, so who did? Yeah, whether we could get accurate recordings from them, I'm not sure, but
Okay.
that is something. But then we did do a birth outcome analysis, and we showed a very strong signal from the blowout and the impact zone. That one we had more extensive analysis in terms of the number of controls, but for low birth weight, term low birth weight, and preterm birth, we see a very strong signal. So we know that a lot of those birth outcomes will translate into diseases into adolescence and adulthood. So it will increase the child's risk of having those diseases. Some children recover, but their overall risk profile is going to be higher. So we do have that, and we're doing, as I'll talk about at the end of the meeting, further analysis on children's health.
Thank you. I want to note that we are running over time, but I'm just going to let it go a little further so we can at least get a few more questions. I do want to make sure we get time for other presentation. And as we said, if we have to go back to this after 7:30, we will. But next question from online is, does the during period include the public being aware of the leak? If so, is there a way to control for people preemptively going to the ED because of exposure concerns?
Short answer is no, because we don't have information on people who might have preemptively went to the ED. As our participant is noting, I'm assuming they mean people go to the ED worrying about the exposure rather than actually having symptoms. It's whether or not that data is captured depends on the practices at that ED. A lot of times if you have been, you realize that they try to triage you to see if the person is experiencing something actually urgent or life-threatening. So there's some screening that goes on if people went there, whether or not they actually ended up being seen by a physician. We don't have access to that information.
Okay, great. Maybe I'll take one more in the room and one more online, but I have the list to get back to afterwards. So I think we had Glenn.
I just want to understand a little bit better the emergency department data limitations. Specifically, you've indicated, all I've heard so far is that someone went there. Does the data include how long they were there? Does it include that they were then moved to ICU and then from there to telemetry? I mean, how much data is provided as part of that in terms of determining the seriousness as opposed to, oh, go home and here's Medicaid,
Absolutely.
whatever.
Yeah, great question. The ED visit data is only for visits that ended up in discharge. The ED visits, sorry, the ED visits that ended up in hospitalization are reported with the hospitalization data, which is another data source we're going to look at separately. So these are folks that ended up being discharged back to the community. The severity is a good question. The data don't have a measure of severity. There are different ways of measuring severity. Sometimes you could look at charges as an estimate, because if it was a intensive visit and a lot of things were done for the individual, that could be reflected in the charges. We currently don't have that data, but perhaps useful to explore that further.
Thank you. So one more from online. When doing this study and comparison, do you consider that so many residents who were impacted the most were relocated and probably went to the doctor or clinics outside of the area where they were? Also, so many just moved away because their health was impacted and got care elsewhere outside of the area. I do not believe this date is accurate for at least one reason, and there are other reasons that I cannot type them all here. I believe
Okay.
they may have meant the data.
Okay. Okay. So yeah, so another limitation of this data is that it's just the ED visits. It doesn't show what else the person may have done. Some of the residents, as I noted earlier, could have chosen to go to their doctor. If their doctor was available, they'll go to the primary care doctor. It also depends on the individual's perception of how severe this is. They feel that they really need to be in the emergency department visit. So that is a limitation, but it's, sorry, I don't see the question anymore. Okay. Okay. It's all right. But I think that the anyone that went to the, sorry, I can't remember the second part of the question. Okay. Okay, so the residents that were relocated and moved away. I also said that people that, if they were temporarily relocated, they had a choice to report their permanent address or not, or report their new address. We don't know exactly what people reported. There's no way for us to verify. I'm assuming that most people probably reported their permanent address. It's an assumption on our part. There's no source of information available for us to know. I think that we are doing some analysis of the mobility, whether how many people moved away permanently and what happened in the following after that. So if individuals moved permanently away from the area during the blowout and they report a different address, they're not included here, right? So if they move temporarily away, the chances are they're still in the data. The data includes all ED visits. We're just not looking at those numbers right now. But if we have, with the help of the mobility data, if it's possible, we can then pursue what happens to people that might have moved away. But again, the other limitation is whether or not you can actually identify those individuals because of these record linkage issues that I mentioned earlier. Sorry, it's getting a little technical.
Thank you. So, and I'm sorry we couldn't get to all of the questions, but I have written down to pick up with Craig, Matt, and Nisam when we get back to this, questions on this. So with that, I'm going to turn it over to Dr. Hong-Hu Liu to just introduce, to Dr. Michael Jarrett to introduce our next presentation.
Well, I'm really pleased to introduce my friend and colleague, Dr. Mike Kleeman from UC Davis. Dr. Kleeman just drove down here today for this event, and he's a world-leading exposure scientist. He fits very complex models. They're called chemical transport models. he's going to explain how those work. But the real power of these models is that we can parse out what came directly from the blowout versus what is coming from cars and trucks and other routine sources in Los Angeles. And that's a really important thing. And then we can start to look at a much wider array of contaminants that could have come from that leak, because his models will estimate not just the conventional pollutants that we see are being monitored, like ozone and particulate matter, but benzene, toluene, xylene, ethylbenzene, several of the aldehydes, which were of serious health concern. So I'd like to turn it over to Dr. Kleeman now, and thank you for joining us tonight.
Thanks, Dr. Jared. And I just want to begin by saying that I'm very glad to be in the room with you. I think that this was an event that obviously touched all of your lives profoundly. And I want to, convey my sort of, grave concern over this. And, hopefully the experience that I've had measuring and modeling air pollution since 1994 in Los Angeles and across California, some of that knowledge can be helpful to understand what the exposures were and to help the health studies then estimate, what the health consequences were from this. So on behalf of the entire team that I'm working with here, we're very glad to be a part of this study. As we had before, I want to begin with a disclaimer that all of this is a work in progress. It hasn't been peer reviewed yet, and your comments today will spark thought. The comments from peer reviewers will spark thought, and there may be additions and sort of refinements to the studies that will come out of those comments and feedback. And so what we'll present today is our best understanding of where we are right now in the process of understanding the exposures, but we don't consider it to be complete yet until we get to that end of that peer review process. So a chemical transport model is a simulation of the atmosphere that's based on the physics and the chemistry that's occurring in the atmosphere. This is a really busy slide. There's a lot going on here, but I just want to try to walk through a couple of key features. In this study, of course, we are very interested in the transport and the chemical reaction of the materials that were released from the blowout. But that material traveled in an atmosphere that had pollution from cars, that had pollution from restaurants, that had pollution from even the plants around us. And all of those pollutants mix into the soup of the atmosphere under the sun, and they will undergo photochemical reactions. So as you look at the fate of those toxic compounds released in the blowout, they'll be traveling downwind and they'll be mixing in the atmosphere, which partially dilutes them, but they'll also be chemically reacting. In order to simulate that realistically, then you have to have a good understanding of all the other emissions around you, because they all go into the soup and they all determine what the reactivity of the atmosphere is. So we base a lot of our modeling on state of the science work that the California Air Resources Board has been doing for 20 or 30 or 50 years, trying to understand the emissions inventories that are, representing Los Angeles. But then also all of the chemistry and physics, all of those various reactions have been studied by chemists across California, across the world. And all of that accumulated knowledge goes into these models. And so this is our best attempt to recreate what happened during the blowout. Now, it's not perfect. We would want measurements if we could get them, and we would want to measure everything that is toxic and that we were concerned about. But it's very, very difficult. We can't go back in time and measure things. We are talking about what's the right comparison community, and your feedback is really important in determining that. But that means that we might have to move that comparison community, and we don't have monitors everywhere. And so the models are playing a role here, trying to fill in the gaps of missing information. They're not perfect, but they do have some sophistication. They do have some skill in doing certain things, and combining that with the measurements hopefully will give us a more robust health study to really understand what's going on. So we come at this humbly. We don't claim that we're perfect, but we do claim that this is what we can do with state of the science, and hopefully it provides some useful information that will go into the health studies. So, with that humble approach, here's what we found so far. So the chemical transport models that we're dealing with are going to include some of the key toxic compounds that we're very interested in, the BTEX compounds, the benzene, toluene, ethylbenzene, and xylene, that were part of that blowout release. We also have the other things in the atmosphere, like those oxidants that I was just mentioning. Ozone is the one that you've all heard about because there's an air quality index for it, but there's many other things in the atmosphere that will react with the BTEX compounds that will then degrade them over time as they go downwind. We also have airborne particles in the atmosphere. We have to be cognizant of that. The results that I'll show today will focus on the gas phase pollutants, the toxic compounds, and we're still working on the particle phase stuff. And we hope to have results for you in the future to present and get your feedback on. One of the unique things about the models, one of the powerful features of it is that you can do that so-called source tagging that I talked about. So taking benzene as an example, many things emit benzene in the atmosphere. Motor vehicles, natural gas combustion in your homes, your water heaters and your stoves, but certainly there was benzene released. When we mix it all in the atmosphere, we want to understand what's coming from the blowout and not have interference for those other sources. And so we can do something called source tagging in these models, which allows us to attach a name to the pollutant as it's emitted to the atmosphere. And then we can keep that name intact as we follow that pollutant around the atmosphere. Even as it mixes in with other pollutants, we can still have that name associated with it, and we can track it downwind and understand then how much came from the blowout versus other sources. So that's one of the really strong points of the model that we have here. Now, the emissions, obviously the composition is this most important question here. What was emitted? What was released into the atmosphere? And we are basing our, first off, the sort of just the bulk rate of release from the blowout on the California Air Resources Board report that looked at the pressure in the well as a function of time and the release rate of pollutants. And that's been peer reviewed and sort of looked at. And so we're going to use that as a starting point. Now, the toxics that we care about, though, were just a tiny, tiny fraction of that blowout material. Most of it was methane and ethane, but the benzene, toluene, ethylbenzene, xylene, they were really, really important trace constituents, really, really tiny amounts, but it only takes a tiny amount to have a health impact. And so we need to know what that is. Now, there's a couple of different data sources that we can look at to answer that question. One of them was measurements of the natural gas in being delivered to residences in the area under the assumption that whatever was in the storage facility is then being shipped to the homes, and you can measure it in the homes, and it should be representative of the composition in the storage facility. We know that that's not a perfect answer, though, because they probably do some cleanup of the gas before it hits the pipeline and before it goes to the houses. And so we just got data as well from measurements around the facility, inside the fence line around the facility, made by, I think, Southern California Gas. And those are another set of measurements that we're looking at. We don't know which is more accurate. We are going to do a high-low analysis and present that to you. We're not trying to, tell you what the best answer is. We're trying to explain what we see as the sort of maximum and minimum amount of those toxic compounds, and then get community feedback and your thoughts, and then eventually peer review as well from our colleagues about what the right answer is. So when we look at this, again, we get these different estimates from measured around the wellhead and measured indoors. The concentrations measured around the wellhead were 6 to 10 times higher than the concentrations measured in the indoor natural gas. So these are not drawn to scale. The trace amount of the BTEX compounds is far less than 1%. And then the amount that was measured in the indoor natural gas was around 6 to 10 times lower than what was measured outside. The results that I'm going to present today are going to be based on that outside measurement, the high estimate for the BTEX concentration in the gas that was blown out. So this is looking at the sort of high end of the exposure estimates that we right now are thinking are realistic. Now, the study region that I'm looking at is focusing in on this yellow map where we have 1 kilometer spatial resolution. We, of course, would like to go down to 100 meters or even 10 meter spatial resolution, but these things are really computationally expensive models. And so we're working on it. We're trying to get there. We want to get to your house, your school, get as much spatial resolution as we can, but we're building it up slowly, and we're starting at 1 kilometer so far and then working our way down. the area is pretty big because we want to have those comparison communities captured with all the same estimates, all the same spatial resolution, so that there's an apples to apples comparison. Again, none of these comparisons are perfect, but we're trying to make them as fair and as bias free because we think that we can still extract useful information from that. We think that even though emergency department visits aren't everything, they should capture part of the problem. And likewise with these models, we're not claiming to capture everything, but they should capture part of the problem. And we want that to be uniform and fair, not changing between the impact zone and the comparison communities. Now, this is a look at the predicted methane concentration. That's the bulk of that blowout material around the whole region that we're modeling at that 1 kilometer resolution over the entire leak period, the entire blowout period. So starting in October all the way to February. So 5 months roughly. You can see the hot spot here. The lights are up, so it doesn't show up very clearly, but there's a hot spot over that impact zone, the semicircle that you saw in the last presentation. And so, thank you. I can get where I need to go right here. So we can see that hot spot. It was the highest ground level methane concentrations in the region, but not the only methane concentrations. And maybe this is a good time to introduce the idea that there's other pollutant sources in Los Angeles. You can see some lighter shaded squares here, and those are landfills and other sources of methane to the atmosphere. They pale in comparison to the blowout, but you do have other sources of methane being released into the atmosphere. And we'll see also for some of the other pollutants as well. Now, if we zoom into that impact zone, your homes, I'm sorry to put such a sanitized name to it, your homes, the impact zone, we can see very clearly then that the concentrations are highest immediately at the well. And then as you move southward, the prevailing winds were moving the material southwards towards your homes. You can see that the concentrations fall off. That's happening mostly because of dilution. The methane doesn't react all that quickly in the atmosphere. And so there will be some reaction going on, but what you're seeing is mostly dilution, sort of things spreading out and mixing upwards in the atmosphere. You can see that the boundary of that high impact zone looks like it's around in the right place. You are dropping the concentrations to a small fraction of the original emissions by the time you get to the edge of that. So we think this modeling confirms what was reported, I think, by health data and just your experiences, that the impact sort of dropped off the further we moved away. And this boundary hopefully accomplishes the purpose of establishing the highest impact zone. You can see also over the community to the west, over the Simi Valley Thousand Oaks community, that we have much, much lower concentrations. The leak did not affect that community. Again, confirming that wasn't going to be subject to any kind of exposure from the blowout. Now, the benzene is the minor toxic compound, but very, very important. So again, far less than 1% of the emissions. So we're measuring things now in parts per million. It's a mixing ratio. We're looking at the number of benzene molecules per the number of total molecules of everything. It's a commonly used air pollution unit. And we can see again that we have a hot spot over the blowout area and impacting into that semicircle. But you'll also see that you have widespread, more diffuse concentrations of benzene. And this again is those other sources. It's the cars and even the natural gas combustion, your water heaters and your stove. So these concentrations are confirmed looking at measurements of benzene across the whole region. We measure this routinely at Central Los Angeles and a few other sites. And so these models are being compared to measurements to try to make sure that they're realistic. So the hotspot over the blowout area is a dominant feature. It's a feature that wouldn't have been there without the blowout. That community was exposed to benzene that they would never have been exposed to. But there is other benzene in the region, and that's an important thing to realize and keep in mind. If we zoom in and look at the Porter Ranch community, the high impact zone, and then the communities to the west, again, we see the very, very obvious hotspot in and around the blowout, and that's caused by the benzene being released. And it's decays away again from atmospheric dilution, mixing, transport, mixing vertically, and then also chemical reaction. Benzene does react faster than methane does until you'll have these chemical reactions going on in the model as well. Now, if we look at toluene, another component of the release during the blowout, you can see even a sort of a greater contrast between the amount that's being released from the, just everyday Los Angeles atmosphere and then what was released from the blowout. And you can see again that the central Los Angeles has concentrations of these pollutants, and in some cases, even higher concentrations than those that were caused by the blowout. Now, over the Porter Ranch area, you can see that the blowout dominates the exposure. That is toluene that you would not have been exposed to had the blowout not happened. So it's not to say that we should ignore the toluene being released. We just have to be cognizant that there's other sources of some of these toxic compounds around. Again, the impacts of the toluene being released from the facility can be revealed by the source tagging, that name tag that we assign to the toluene released from Porter Ranch, from the Aliso Canyon facility. And you can see that in the right. We can track exactly how much of that toluene over Porter Ranch came from the facility. And that has to be held accountable. That is material that was released from the blowout. And we want to keep track of that and include that in all of our health studies. Now, just a quick look again at the time evolution of this. On these plots, I've got time on the lower axis and I've got concentration on the upper axis. I've got two plots, one for methane and one for benzene. And then I've got two communities. The red community is that comparison community to the west, Simi Valley, Thousand Oaks. And then the blue lines are the high impact zone. Again, that sanitized name, I don't like it, but it's your communities, what the average person experienced in those communities. And you can see again very clearly that you've got much, much higher concentrations in the high impact zone than you do in the comparison community. Again, establishing, I think, confidence in the comparison community was not exposed to this blowout. We might move the comparison community with your feedback, and we'll redo this analysis and show you the plots again. But as it looks right now, that comparison community did not suffer directly from the effects of the blowout the way that the Porter Ranch community did. And so we think it's a basis for the health studies that follow. Now, I just want to close this out by saying that we don't, again, claim that these models have all the toxic compounds that were released from the blowout. In fact, they probably almost certainly don't. I won't say probably, they almost certainly don't. But the spatial patterns and the sort of time patterns, all of this pollution was transported together, was reacting with the same oxidants at the same time. So we think that the benzene and the toluene and those other compounds that we do track are representative of a broader suite of toxic compounds. And if we look at some epidemiology, some health studies based on spatial patterns of health effects and spatial patterns of pollutants, or we look at health studies based on time series of health effects and time series of pollutant exposures, we think that these toxic compounds that we are tracking can serve as canaries. They can serve as fingerprints for that other stuff that we're not tracking. And hopefully, again, it will provide some useful insights. So 30 plus years of trying to do this stuff is at your disposal. We're trying to provide useful information, and we're trying to help support different dimensions of the study that wouldn't be possible because we can't go back in time and make measurements. We come at it humbly. We don't think that we know everything, but we hope that we know something and that it can help this, and it can help everybody move forward with the studies that are coming. So with that, I will turn it back to somebody to answer questions or to for the broader panel.
Thanks, Dr. Kleeman. So we are at 7:25. Does anybody have to leave at 7:30? Okay, so we're going to do some questions and answers, and then okay, we do questions and answers, and we're going to get some study updates. We have an evaluation, and then we're going to go back to more questions. Okay, so but let's at least take some questions here. Anybody in there? Okay. Patty. Craig. Remind me of your name. I know I've met you before. You go. I'm sorry? You go. Ron? Okay, let's start with Patty.
Okay, thank you. So last meeting, it was mentioned that you folks got this massive file from SoCal Gas, and you were going to look at it to see if you could find a list of the comprehensive list of chemicals that they used on their well and on their gas. Were you able to find it? I guess it's for Dr. Jarrett.
Yeah, so we have documented everything that we got from the gas company. And some of what you saw tonight was informed by what they gave us. So those measurements of the benzene, toluene, xylene, ethyl benzene that were close to the wellhead at the time of the leak. We have requested multiple times, but not received compositional analysis for what was used in the well kill attempts. So if there's a big uncertainty here, we know from field observations, we were here at the time, from talking to community members, that many houses experienced this oily, rust-like residue. Sampling indoors, we found lots of evidence of that when we were doing the so-called dust swabs. So we know that it happened. We don't have a good estimate yet. We're not giving up, and we've asked the UCLA lawyers to ask the question again, because the last two answers we got from the legal counsel at SoCal Gas are, well, we gave you 4 gigabytes of data. You know, why don't you go through it? And, you know, in that sense, we have gone through it and it's not there. But the benzene levels that were measured were certainly very helpful because, you know, our original other approach was to try and look at the composition of the gas from reports, like the report that was where there was sampling done during there was that uncontrolled fire that happened at the field, and several other consulting reports. But, and then our own analysis where we've gone out and sampled at 22 homes repeatedly. But we do have that new piece of information, which has really changed the concentrations that we can attribute to the well blowout.
So is there any way of putting pressure again on LA County like we were trying to in the CAG and other community members to force the LA County to issue a subpoena to SoCal Gas to get that information?
We're told that because it's no longer considered a public health emergency, that they don't have the authority to do that. Well,
And I'm sure
Well-
more and more people are getting sick all the time. Cumulative damage is happening to people. More people are getting diagnosed with cancer. So I would think that still is a public health emergency, but, and you probably agree with me, but.
yeah, well, we're trying to get that information every legal route possible. And we'll go back to them and we have had our council request that from their council, and their council has told us they don't have the authority anymore. Definitely.
Yeah. Thank you. We have one question online. For the toxic compounds that may not have been accounted for, what about soil sampling? Was that taken into account?
Analysis. I think that that's more a question of deposition. How far did the toxic compounds go, and how far did the plume spread, so to speak? And I think that we are looking for all ways to try to ground truth these models, to try to compare them to measurements in every way possible. So I think that's a great suggestion. We also are going to try to look at satellite observations of the plume and that measures the total column depth. And so we're going to try to compare our models to those observations as well. We also, I think Mike mentioned already some of the swabs that were done, looking at some of the deposition of the rusty, oily looking material. So all of that's forthcoming. I think we've been focusing really hard on trying to get the base sort of calculations to look realistic. And now more ground truthing is on the docket for what's next. Absolutely.
Thanks. Okay, I'm gonna, if you're interested in hearing about the study updates, you can check our recording. And there's an evaluation, you can link to it online if you get a chance. We'd love to hear how we're doing and see how we can improve our presentations to you guys. So that's a way for us to get that information. Okay, let's move to Nisam.
Oh, can we further our online folks?
Thanks. My name is Isam Najim. I'm a resident. I don't know how many questions you can tolerate from me. So you gave two presentations and I have questions on both, but I'll start with your presentation if you don't mind. You referred initially to the maximum and to the quote unquote minimum based on the in-house gas measurements. But that is utterly not representative of the emissions during an uncontrolled blowout. Because at the end of the day, it's not the methane that matters, as you noted, it's the chemicals that were sucked out of the field with that blowout. And under controlled conditions, they have a full industrial process to do separation of oil out of the gas. That was absent during the drawing. So I don't know if your modeling was based on the maximum, or was it the average, or what?
It was based on the maximum of the measurements around the facility during the blowout,
Okay,
inside the fence line.
okay, thank you. And regarding the slide with the estimates per person, you have an average estimate per person.
Mhm.
Recognizing that it goes from 0 on roughly on the outside to much higher on the inside.
Right.
If I may suggest in the presentation of these data, not that be an average data point, but rather a range that represents the minimum 5th and upper 95th percentile to show that it extends well above that average.
And I'm the stick figure when it comes to the statistics. I'm the
Okay.
simpleton. So, that was just done to illustrate that the control, community is much, much lower than the high impact zone. But beyond that, there will be no statistics based on that whatsoever.
Okay.
I rely on my expert colleagues to do
Okay.
all of that.
All right. Thank you. I'll give the opportunity to other individuals, and if there's more time, I'll ask a question about the first presentation. Thank you.
Thank you. Let's move to Craig.
Thank you. Craig Galante, resident. So I want to compound some of the things Isam was saying, that the uncontrolled blowout, crude oil was what was found in our neighborhoods and our kids' toys and our pools and all that. So all the benzene and toluene has to be taken into consideration of those materials, because it's unscrubbed is the term we got to know, and that's what's in the household gas. It's scrubbed. So I wanted to, and maybe this was answered, and I apologize if I didn't get it. The numbers that you used for benzene, for instance, yes, thank you. The line chart. The line chart comparison to control and
That's
impact zone.
the very end.
Yes, thank you. So is that average during a 24-hour period?
That is, each data point, I believe, is a 24-hour average.
Okay, so as we know, it's a windy area. There was obviously peaks. Are you going to be able to assess that? Because
Again, this is the stick figure cartoon of a much more complex analysis. We have hourly data.
Okay.
But you have to be cognizant of what these models can and can't do. So if we choose to look at hourly data, what we would have to do would be to take all the night hours and average them for a week or something like that. These models are not good at predicting individual random events. They're good at predicting averages across. And so somehow you have to do enough spatial or time averaging in order to get a representative answer. And so if we want to look at peaks, we'll have to look at peaks across a longer time period. And it's going to get technical if we dive into the details, but
Well, okay, you worry about the technical and you worry about the details, and these guys will help you with the statistics.
Yep.
But from the community's perspective, and this is all doable. I mean,
Yeah, yeah. No, we have the data.
the models are robust, I'm
We have
sure.
terabytes and terabytes of data,
Terrific.
and it's all hourly average, and in its raw form. So,
Great.
yeah, we
Just,
got it.
just to remind everyone, the WHO says there is no safe exposure to benzene.
Yep.
And the California's hurdle is 1 part per billion in a 8-hour or 12-hour day. But also, if you have a peak of, I forgot exactly, I think it's 6 parts per billion in 1 hour. Is it 8? Okay, 8 in 1 hour. Now I know there was capturing of several incidences where it was above 8, as high as 20, if not mistaken, maybe 30. That's what we were exposed to.
Mhm.
And the model must, this is dilution in my mind, because if you're going for long periods of time of average exposures,
Right.
that's not truly the health impact.
I think that, again, these models aren't designed to answer every question, but hopefully they provide some information that's useful to do as much as we can. So I fully understand your point, and I fully agree with your point. There's only so much I can squeeze out of this model.
Okay.
So
So then.
with apologies.
I understand. And and you've been great. Thank you. Thanks for driving down. I saw you rush in with me and you maybe just pulled up. So thanks
Yeah,
for
yeah.
driving down. It's appreciated. But I think we have to take an objective view here and say, if this modeling is so limited, is it the best use of the limited funds? Because what we need, and I'm hoping to hear something about it tonight, is what happened to us? What's the clinical evaluation to us? And if this model, we already know we've been exposed to benzene and toluene and all the BTEXs. I don't want to see money spent in a knowledge cul-de-sac here because the model is limiting. So I offer that up. I think that needs to be challenged. Where's the money going? Where are we with the clinical? How does this complement? Is this necessary? And would it change the clinical protocols that are envisioned?
I won't answer a big picture question. I will say that if you have ideas of how to get those exposures at a personal level to peak concentrations, you should definitely spend the money on that instead of on me.
Okay, fair enough. Humble, appreciate it. And there's plenty of studies out there on benzene. The combinations gets really, really confusing because there's no good studies on that. But we know that the proximity populations, because we have recorded data of benzene levels that peaked at 8, 10, 20. Isam, do you remember? I think maybe even 30 at some of the monitoring stations.
Well,
In the neighborhoods.
I shouldn't make comments in the realm of the health studies, but I will make one quick comment. If we had a big enough data set of those measurements, those observations, then we would have statistical power to do a very, very powerful comprehensive health study. But I think, as I introduced at the beginning of the presentation, we just don't have that. We don't have enough measurements to drive all of the health studies that we want to do based on measurements solely. And so we have to rely on models to try to fill in the missing gap because there's no way to go back and make the measurements. There just isn't enough.
Understand. And this is why I was a member of the CAG and some others in this room with me, Brian and Patty. This is exactly what we are stressing. And what does the community want in the health study? We did not want to be hindered or constrained by these sort of models that are non-conclusive. And that's what we're seeing here. That's why we insisted that the primary funds be spent on clinical evaluations. What happened to the people? Okay.
I think
So,
Dr. Jarrett, oh, sorry, I didn't mean to interrupt.
so it's time to challenge that.
Oh.
Thank you for
I'm
allowing
sorry.
me to go so long.
Dr. Jarrett might want to weigh in. on that.
Well, I think first, Dr. Kleeman is a little bit too humble about his model. They do predict with very high accuracy. We can look at those peak exposures, and it's a really good idea to do that. But yeah, we can use peak in the epidemiological studies, so we'll certainly be looking at that. We're not going to get any of the peaks. Those were from grab samples, so those were other trigger samples. I believe the highest that I saw was about 9 parts per billion in the measurements. Interestingly, afterwards in Porter Ranch Estates, when the AQMD had left their facility there and they were doing the SUMA canister sampling. It was triggered either from 5 parts per million of methane or 5 parts per billion of total VOCs. What we saw in those data, and we published it in a peer-reviewed paper, is that there were several instances where there were 12, 16 after the leak was plugged. And that's certainly an ongoing concern for us. Now, I know that Argos Scientific has done a lot to set up a fence line monitoring system. It's really just coming on stream now. And, you know, I don't think that's Argos' fault or, you know, but.
But-
One is California standard, right? And they were set at 10. So it could have been going on at 8 or 9 all day long.
Yeah, let's get into that more after if we could, because I have a few other people. That's, unless you
Yeah,
wanted to
so
answer
I
that.
just round it out and say that we can do hourly peaks, so we could put some measures of peaks in, but they're not going to be as high as those samples that were at 8 or 9, because even averaging over an hour is going to pollute them somewhat.
Even if you did that, would that change? Thanks for those at home. Even if you did that on the peaks, and you could call it worst case exposure, perhaps, whatever. Would that change the way you're doing the clinical evaluations?
Well, we are doing clinical evaluations so that we can detect, you know, metabolomic biomarkers of benzene and other chemicals which we know were released. So it already has, you know, led to a targeting. And we have Dr. Wendy Robbins on the line who's leading the biomarker component of the study, if you want more detail. But sure, it definitely has. I mean, we're targeting those metabolites and doing that in the blood analysis that we'll be collecting later this year.
And we can stay after and we could stay after and continue on this thread. I just want to make sure the other people with questions get a chance. So Kyoko, grab your mic.
No.
He was the previous.
One of the first ones
Oh, for the first section?
for any section.
I had you on the first presentation.
Okay, so I hear elevated level, always elevated level visit of emergency visit, that what we have a problem with is and repeated on and on we hear compared to the baseline level in the other places in region, it's not that bad. So that's not good. I mean, that's not what's going on in the community. It's definitely there is a health impact. So how your study will help actually health department always say, yeah, it's very elevated, but compared to the baseline level, it's not that bad. Yes, but it's bad, so you should take care, be careful. And that's not really helping. So and also there is no such a thing to actually vulnerable populations specifically to compare to whatever the level is. Also the level that California or federal set up as a screening level or minimum level exposure will cause health impact. That is not cumulative impact. So when you actually see it, when 1 ppm of whatever benzene or that, and then you actually exposed to another one, and then we exposed to millions of, bunch of them to rinse that, and then, suddenly there's not just one exposure. So do you evaluate cumulative, all those toxics, and then evaluate what's the health impact to our body? And also, biggest question is how, did I actually ask the question, how your health study will help, somehow a health department to say, this is not good, don't compare to the baseline, and then, you're okay. It's definitely, it's not okay. And, we need to know, and we need to have somebody actually said, this is no good, so you have to change. So we actually are protected, everyday life. So how your study will help that?
Yeah, thanks for the question. Well, I think the ED differences that were presented, we look across California, there are lots of places that are very poor, where they don't have very good access to medical care, Imperial County, Central Valley. So they tend to have a higher baseline rate of ED visits because they're using the emergency room as their physician, because they don't have regular access to care, or their access to care is very poor. So that's one of the reasons, and that's one of the concerns about using ED visits, is that they are partly a reflection of the symptoms that are caused from the blowout, but they could also be partly a reflection of those underlying differences in access to medical care. But what our model does is it allows us to say, well, here we've got two very similar communities. What did that actual leak do to their health outcomes? So I think that does a lot. And Craig asked the question earlier, like, what's the elevated rate? It was about going from 0.4% to about 2.6. So you're looking at something that's like, yeah, so you're looking at an increase that's more than 6.5 times. And so, or 650%. So it is a big increase, and environmental health, we don't see increases like that very often. We have very subtle effects normally. So it is showing that, at least during that blowout period, there was a very substantial impact on population health in the community. And maybe Dr. Brown wants to add something.
Thank you. So if I understand your question, what you really are interested in trying to see what happens to people over time, extended length of exposure, what is the health impact? And to do that kind of analysis, you need comprehensive data on everything that an individual did. For example, there are data sources such as Medicare data. Medicare data captures doctor visits, hospitalizations, ED visits, labs, everything. And it also allows you to follow individuals over time. So you could select people that were residents in the area and then see what happens to them over time. So those kind of analysis are possible. We're trying to get the data. The biggest challenge we have is it's just the nature of a healthcare system that data are siloed all over the place, right? So if you have, depending on what your insurance is today, they have all your information. If you change your insurance and go to Kaiser, for example, Kaiser has your information for the time that you're there. We currently, there is a new data set that's being developed in California that has everything over time, but that only starts in 2018. It's not late, it's not including data. So that's a huge challenge for us to try to see what happens to people over time. We're still trying to get access to the Medicare data. It's only the older adults, so it's not everybody, but at least it allows you to answer the question you're asking for some of the people in the area.
Thanks. So we have Matt, Ron, Yael, and Gary. Did I miss anybody else? And Nisa, I'm back from the first, but yeah, I'm just trying to stay on this topic. Then we're gonna get 5 minutes of just a study update, so for people who are interested in what's going on in the whole study. And then we can stay even later and get back to the first round and more questions here. So let's go to Matt.
Hey, my name is Matt Pacugo, president of Save Porter Ranch. So you get data from SoCal Gas. How do you weight that, given their proven history of misinformation to anyone that will listen to them?
The measured benzene, toluene, ethylbenzene, xylene concentrations that we got from SoCal Gas were the highest estimate that we could find among the different data sources that we looked to. We think that it's representative of the, the unfiltered, the uncleaned up, the sort of raw emissions from the blowout. But we have no way of trying to make sure that they didn't somehow alter the data.
That's what I'm talking about.
Yeah,
Because that's what they do.
unfortunately, that wouldn't be my realm of expertise on the study team. So I wish I could give you a definite answer to that, but I'll look to probably a lawyer to answer that question. Unfortunately, I can't.
That's it.
I could just say that, the levels that we observed from those measurement sites. I had a question for you, Christina, because you interrogated the data most closely. What were the highest levels of benzene that were measured close to the site? It was on the order of 1,500 parts per billion, I think. Some of them even higher. So it did, so we had, measurements near the blowout that were showing levels of benzene that were 1,000 to 5,000 or more parts per billion. So hugely elevated levels. I can't imagine a scenario where the proponent of that facility would supply data like that if they were trying to somehow underestimate it, because those are really high levels. So there was, in our mind, some veracity to those measurements because they were recording such high levels. And they were higher than what we saw from the scientific literature from the UC Irvine study as well. So
maybe just one other point to Matt's question. The model predictions then are compared to measurements made by other groups further downwind. And if the mixing and the chemistry and all that is working in the model, then if you can compare to those downwind measurements and they look like they are somewhat reasonable, then that gives you confidence that your upstream input data was correct. And so we have done those downwind comparisons where we have the fence line monitoring and the monitoring deeper across the community. And those quality control checks are being done, if that gives you any comfort, if there can be any comfort. I understand.
Thank you. What, Ron is next?
First, I want to thank you for coming out this evening and for your hospitality. Appreciate it. This has been going on for almost 10 years. The federal, state, county, city, and all the various regulatory agencies have completely failed us. They don't care. I'm not expecting them to do anything. They failed during the disaster. They're failing now. They're not going to do anything for us. I appreciate all the studies that you've done here, but sometimes it's information for information's sake. Nobody has told this community what is going to happen to each one of us in terms of a benefit from all the money that's been spent doing these things. I don't know if anybody can stand up in this room and say that they have experienced any benefit from all the money that's been spent. The city came in and they sued The Southern California Gas, they got a settlement. Not a penny came back to Porter Ranch residents or the community. Can you tell me this evening, after all these studies are done, I can see this is because of the severe limitation on the data. I personally went to a doctor. I didn't go through the emergency room. So my information is not captured and I'm not blaming you for that, but I'm just saying there's a severe limitation on the data. What benefit can you say tonight, tell us tonight, are we as individual residents in Porter Ranch going to receive? I'm not talking about just money, something. If it is close to zero, then all of this is for naught. And it's 10 years out. I mean, you look around and it's not just here in LA, in California, look at Palestine, this big spill of the train wreck over there. People are still suffering. Nothing has been done. They did a minor cleanup out there. So again, my question is, what is going to come of this and what specifically are the residents in this room and everybody here in Porter Ranch going to see in the near future? Thank you.
I mean, I understand your frustration and, you know, I know it's been a long time. As scientists, we are not advocates. We are trying to supply the best, most rigorous results we can. In the past, many government actions have been prompted by scientific information that presents a clear indication that there's a public health danger. And I think what we've shown on the birth outcome study, on this emergency room study, on the mental health study with the focus groups is all pointing to a fairly substantial impact on people's health. As we go into our clinical exams this year, we will have very detailed blood biomarkers that will, none of this can be definitive. It's all science. There's always uncertainty, but it will say when we look at the blood of people in this area and their urine, do we see indications of higher contamination in their body systems? Do we see clinically significant differences in their cognitive function, in their cardiovascular system? So all of that is going to give you the information that you need as a community to better advocate for making sure that the facility is run in a safe manner, or if necessary, it's closed down. So I think that, you know,
We had a public meeting and they told us that there is no emergency valve on any of the pumps up there, none. And they're not going to put any in there. We're sitting on a ticking time bomb again and nobody is doing anything.
yeah, I mean, I sympathize. And, you know, we're doing our best to get as much information as we can.
I think the facility might be giving us
The closing
hint.
time, yeah.
We were supposed to be out, but I know we have two more people that had questions. We had about 5 minutes of overall study updates that'll describe what's coming next. We had Yael and Gary. Would you be okay if we do the study updates? Oh, yeah, or we could take it now that we've got lights on. I just didn't want this to be locked in. Is that okay? Yeah, I just want everybody, people can stay, we can stay as long as they don't start locking us up. So Dr. Jarrett, would you want to give us those study updates?
Sure. Have a slide for this? We do. Yeah, so I just wanted to give you an update on where we're at with the key components of the study. And we've already presented to you the birth outcome data, the focus group data, and the remote sensing data. So the birth outcome data was submitted to the journal Science Advances, which is a high impact journal. We resubmitted it for the first time in January, we wrote to the editors at least 7 separate times to say, the community really wants results. We want to give them results. Why can't we get our reviews back? And you may have heard that there's a little bit of chaos in academia these days due to all the federal funding cuts. So there are a lot of people that are scrambling just to keep their jobs, and everything, it seems, is delayed. It took until about 2 weeks ago to get the reviews. The second round of reviews, there were a few comments which we were able to address, and we resubmitted the paper again, and we expect the decision to be imminent, and it will be published, I would expect, within the next 2 months. Focus groups is to be submitted very shortly. Remote sensing as well. I've reviewed it. It's a very interesting piece of work. So those are coming along. So that's using the satellite images and the images that were taken from aircraft that were flying over the site during the leak period. And that allows us to see the total column concentrations of methane so that we can interrogate the size of our impact zone. And, we think from those plus Dr. Kleeman's analysis and what we've done to look at complaint data, somewhere in that, 5 to 7 mile range is probably the right impact zone. And then we've had a really significant delay in the metabolomics blood spot request. So for the children, every child in California gets a heel stick. The blood spot is preserved and saved. And we've made the order for 2,800 blood spots. Some of these are children that later developed autism spectrum disorder. Some are children that were from low birth weight babies. And we can literally analyze 10,000 molecules in their blood and do complicated analyses to say, was there something either on an ongoing basis or during the blowout that perturbed either the contaminants that are in their blood or biomarkers which would be prognostic indicators of future health effects. Apparently, because there have been cutbacks at the state level, they're down to 1 half-time person. So, she works 2.5 days a week to handle all of the requests for every biomonitoring sample in the state of California. We can't do anything about that. We have their phone number. We've been talking to them, but that has been delayed. With the resident health survey, we've got a survey instrument, and the protocols have been approved by our scientific oversight committee. We're just refining the automated system that we're going to ask them about. We have a consultant that has it's been in negotiation for a long time with this consultant, but so that we can get the draws of all the address-based participants for the study. And then we're going to do these random samples so that what we get is going to be a population representative sample for the area around the leak or around the facility, and then in control areas. So that is going to be rolling out in the next couple of months. And then from that, we are doing recruitment for 600 clinical exams, 400 in the affected community and 200. And it's a very extensive exam. Our nursing staff are in the field right now. They're piloting this method, and they're doing that around the areas that were burned by the wildfires. But we're learning a lot from what they're doing with those biomarkers. Do we wish that we had biomarkers like that were taken within 2 or 3 months of the leak? Absolutely, we do. But yeah,
that we have done a lot of work. Actually, the platform already created, which will be the right cap. And we will leverage the accuracy of the sampling part, which is critical because this is really address-based because the physical location is very important. So as Dr. Jerry mentioned, we work with a vendor, STS, and we right now, a lot of people work, but right now final stage already through, and we will get an accurate sampling frame, which will be not just regular post office, which where all the other study use. We actually used one will be supplemented by the voter database and the consumer database. So that will cover at least up to 98% of the accuracy of the available addresses. So that is coming. No, that's for the resident health survey.
That's,
Yeah,
and-
the cancer study, that's a different one. We already got the data and it's in the process. And the exam that is from 2015 to 2021. That range of data.
What did I do there? Okay, sorry. Here. Okay, so I'll just finish up with the study update. So we have now completed field sampling at 40 locations for indoor, outdoor particulate matter. All of that's been speciated for metals. So if there are any metals in the particles that we could trace back to the facility, we'll be able to look at that. And we've done it in control areas that are in Simi Valley, but also all over Los Angeles. We've also done residential gas sampling in 22 homes, 6 times in each home. And we're going to present both of these results at the next community meeting. We have, as Dr. Liu said, ongoing cancer registry analysis, additional healthcare utilization, the hospitalization data. We're actively working on the autism spectrum disorder registry data. We have the Quest blood test data, and we have California Health Interview Survey data. And a lot of this, we've been waiting until we get the first round of models from Dr. Kleeman, which we now have. So those are moving along, and they're moving quite well. And we're in the process to receive all the records and results for individuals that have volunteered health data. So that is not something we can do quantitative analysis on, but we can certainly look at the data and try to ascertain whether we're seeing some commonalities in what people are volunteering. And then we're going to be adding all this new content to the websites. And then in January 2026, will be reviewed by the Scientific Oversight Committee about whether the study should continue for the final 2 years. And they've given us very detailed assessment guidelines, and we're working toward that so that we will successfully complete the study.
Just any quick questions just on the study update, and then we'll get back to the questions on Dr. Kleeman's analysis, and then back to the ED visit. So any just quick questions about the study updates? Craig?
Yeah, several. Try to be brief. So the January 26th, the SOC review, you said you feel very optimistic that you can provide them with enough information to continue the study. The reason I ask is you probably will not have the clinical evaluations done in time for that January 26th review, or will you?
We're still within scope for what the original statement of work said we were going to be doing at that time. The major delays have been with the provision of health records from the state, and some minor delays internally because UCLA and the contractor for the survey were having some contractual
For the
disagreements.
survey, for the clinical
For-
protocol?
No, not the protocol, but the residential health survey. And then from that residential health survey, we draw the clinical exam. But we're well within the time limits for that clinical exam. So I don't think that's going to be an issue.
Okay, because it's been always difficult for me to appreciate the pace in which academia and government moves. I come from a corporate environment. This pace is completely unacceptable, completely. No one would have a job in the companies that I work for that things took this long. For instance, you're sitting on the cancer data. I'm thrilled to see that you have an autism registry, so you can look at that too. This is primary data. You already have it. An analysis could be done. And then you want to layer on mapping with what is done with from Dr. Kleinman. You could do it just on block group or on zip code alone. I don't see why that can't be done expeditiously. And I'll say for the record, I am very, very concerned that you guys are not going to have enough evidence to go back to the SOC in January because of this pace. And they're going to say, this seems inconclusive. We're not going to continue this. I think that's exactly the path we're on. And to say I feel betrayed is a complete understatement. So if you can address why you can't move forward with cancer, autism, maybe additional healthcare utilization, and give me a date of when the clinical exams will begin. Oh, and why can't we see the protocol so that we can weigh in on it? There was a lot of questions.
All the protocols are online already.
I was there today. I could not find them.
Well, I guess Christina's going to go
We'll get
find
you
that
the link.
for us.
Thank you.
Um,
Okay, so let's move on to the other one, cancer registry. Why can't that be done today?
Well, we are doing it, but I mean, these are not straightforward analyses, right? So the last thing we want to do is come out here and say, if we did a really slipshod job and found nothing and came out and said that publicly, that there's no cancer risk increased, would you be happy with that?
No, of course not. We're counting on you to have the proper rigor. Yes. What's the
So-
delay then?
Yeah, we actually internally already done a lot of work of cancer analysis. We want to make sure it's solid before we can present. We actually we did several rounds internally. We present internally, discuss internally. We looked at every possible cancer associated with pollution. And we got the full list and did all those systematic approach. We will get that. We're not actually waiting for Dr. Clement's results. We're doing the cancer. Yeah, we actually doing it in parallel. I just want to let you know.
I mean,
that.
we're going to
Okay.
use
Yeah.
those results as well, but
Yeah.
but we are analyzing it. It's ongoing. It did take a long time to get it from the state as well, and that's been, you know, a perpetual problem, not just for this study, but for a lot of other studies. And then I guess timeframe for the cancer analysis.
Please.
I think we're probably looking at early fall of this year.
So potentially for the next community meeting?
Potentially, yes.
Thank
but-
you. That would answer that gentleman's question over there about where's the value added for this community? And the lightning rod was the low birth weights. I mean, that's serious stuff. And yeah.
Yeah, and we are actively working on the autism data. It's extremely complicated because they've, in the process, somewhere around 2017, they changed the definitions that are used to declare autism in the state. So everybody goes up quite a bit based on those clinical diagnostic definitions. And, you know, trying to know whether or not when we do the comparison between here and other communities, whether or not that's a fair comparison because there's so much going on in terms of the change in rates. So we're grappling with that, but we have, you know, reams and reams of statistical analysis that's already done. We just don't want to put, you know, we understand and we're working really hard and we're trying to get these analysis out to the community as fast as we can. But we don't want to put out data until we really feel like we're confident in the results. And, you know, if that means we have to wait a few extra months to get them, I think it's worth the wait. And, you know, with all due respect, we're not a corporation, right? We're not trying to just make money and throw things at the wall and see what sticks. We're trying to produce really high quality science that is going to withstand peer review. And in the end, that ultimately gives the community and empowers the community to have that kind of information available to them. But I hear you, and we are working as hard as we can to get these analyses cranked out. And you'll be seeing a lot more this year, I do expect, so.
We look forward to it. Thank you.
Good, thank you. Oh, Julie, question on the study updates?
Yeah.
Okay.
Thank you. I really appreciate all of your time. I know this is very complicated and difficult, but I just wrote myself a note, just the last few words that you said. I'm just thinking that we as a community need the data, and we need it before the study is closed down, whenever that may happen. That last point really makes me worried, where it says January 26th, SOC will begin their review of whether the study should continue. You know, we believe in this community that we're living and waiting for another disaster to happen. We just don't know when it will be. And we all know that Aliso Canyon has to be shut down. We can't live beside a nuclear bomb, and that's what's happening to us day to day. We try to forget about it. We try to go on with our lives. I just count my blessings that my kids were all grown up and had moved away before it happened. As I get older, I worry, and that's why the blood studies are so important. And I don't even know if you'll have time to, I don't know how many people, although if you're talking about maybe cancer studies, I don't know how many people have already passed on from leukemia. So I think the last few words that you said was data, high quality science. We need that. We are living in fear that your study will just terminate, and we will never know that. And we will continue having Aliso Canyon open forever, because certainly the political leaders are influenced by the gas company. And we know already at this point in time, we were told years ago that it would be closed down by this time. Obviously not. So we appreciate what you're doing, but it's so urgent that you're able to complete your study in a timely way before it's terminated. And I don't even know how much money is left for your study.
Yeah,
But
well,
we depend on you.
let's put it this way, I'd be extremely surprised if it's going to be terminated because of the extensive amount of progress we've made and how I know it seems like forever, but this is what we said. We're going to take 3 years to do this, 3.5 years to do this, 5 years to do some of the analyses. Like, they're not due until the very end of the study. And that was partly in recognition for just how complicated these analyses are when you really dig into the data. And that's, why we're rushing, because we absolutely do want to finish this study, and nobody wants to put in the amount of sweat and time that everybody on this team, that's now about 70 plus people, if we include all the students and the admin staff that support it, we want to see it to its fruition. And we're really what we're driving toward, is to make sure that we get all those promised analyses to you as quickly as possible, and then into the published literature, so that they have credibility with government and other decision makers.
Yeah, the coming health survey and the clinical assessment, that's largely the primary data collection, and that's the population base. So the result from that will support the community eventually to have a conclusion on what's the impact. So that's something is coming. It's very important. Please be patient. We work as hard as we can, and we'll try to finish that on time. And there could be some other things out of our control, but within our team, we work very hard. Look at this and get all those. Actually, try to get ahead of the time. And certain things, as Dr. Jerry mentioned, a lot of those contractual work, paperwork, all those certain things out of beyond this group. But from our point of view, we have done all we can, and we'll continue to do so. Yeah.
Just to be fair, for the cancer and the autism, you're beyond favorable. You have the data. Correct?
Yes. Yeah. But remember, the cancer data the state took a long time. We, keep bugging them, eventually got data. we actually, once we got data, we start to analyze internally already, we're not waiting for anything. Yeah, we just. I'm sorry? How long have you had? A few months.
Okay, Brian, was your question about the study updates also?
Yes, I'm sort of general. I've been here for all the meetings, as some of you know me. And I'm impressed by the fact that you have presented information a couple of times now, which is impressive and is obvious that there is a problem. I don't think anybody can deny that there is a problem. I'm a little concerned, and I realize that you're scientists, and you're taking the position that I can't be emotional about this. I want to be practical about what I'm doing and honest and direct and thorough. I got it. However, when we look at that last line item there, the SOC, I can speak for myself that the public health department is the enemy. I don't know that how many other people in this room or how many other people feel the same way as I do, but I suspect that there's quite a few. And if the SOC is reporting to the Department of Public Health, I don't think you have a prayer in hell of them supporting you. Which means to me that you have to take a very positive, very direct, and very honest position, not just information, but a position on what should be done from here. There are too many people here that may be injured in a great way in the future. And we don't know that. And we won't find that out unless you do a thorough study and you complete the job and evaluate the people. So I'm really disappointed. I am hopeful. I've talked to all of you once or twice in the past. You know that I have not been abusive in this, and I'm trying not to be now. But I am telling you that the community is not going to sit well with and I'm not saying shoddy, but with a result that is not emotional in some way. Because we all know that there is people that have been hurt and will probably be hurt in the future. And the fact that you're not getting information in a timely fashion, that the state or city or anybody is giving you a hard time, I'd like to know who or what disaster is more important than this in the state of California. Which one? I would think that a person who is, if they're down to one person who is doing a lot of work, why isn't that person putting this at the top of the heap? If there is a disaster where people are being injured and it's more important than this one, fine, that person should attack that first. But if this is as important as we all believe it is, and we have been told that this is the largest and worst disaster of its kind in the nation ever, you would think that this would take high priority. And I don't hear that. And I don't hear you presenting it in that way either. So I just want to make sure that you understand that from my perspective, I don't think it's going along with the right emphasis. And I don't think that you're pushing to get the job done effectively. And if that last line is there, I believe you have a major problem in completing this. Thanks.
Well, I can say that the Scientific Oversight Committee, although they were appointed by Public Health, they are independent, and that's how they're supposed to operate. And I have confidence that the scientists we've been interacting with are not in anybody's control per se. They're not trying to grind an axe because some are, and some are independent scientists that are, are working on their own, or they're retired. They don't answer to anyone. Yeah, I'm not, so.
You guys have to come back to the SOC with an exceedingly compelling argument that this thing has to complete. And if it needs more funding, then then lobby for more funding or seek grants. Maybe you guys should be seeking NIH grants right now, if you're not already. But you must have a compelling scientific reason for this study to be completed, to be the gold standard. I mean, your guys' names is on it too. I would think you'd want that.
I just wanted to note that this is a contractual requirement. This wasn't, okay, it wasn't triggered by anything in particular. It's that when we get to a certain time point in the study. So, okay.
But it also, yes, it's a stake in the ground. And if you drag your feet, everyone in this room, this community has to say, are you dragging your feet because you're being pure scientists and stick around with groups? Or drag it out long enough because this is the directive we're getting. Hey guys, come on. We've been sitting here on this for 10 years. We've been betrayed by everyone. You can just drag your feet along and along and along, and then you come to this contractual obligation that we decided. That we're arm's length. You could say the SOC decided we are not continuing, so we're ending the study here. That's exactly what I'm feeling is going to happen.
Well, I hope it doesn't, and we're working really hard to make sure that that doesn't happen. And we don't have any indication from the SOC of any level of great dissatisfaction with what we're doing, and exactly the opposite, that they.
Okay, so let's, I'm well taken, and if there's anything we can do to
Yeah.
give further response, but I do want to, I know Yale's been.
And I just want to quickly, answer the idea that we're not pushing the state hard enough. I mean, we've, like Dr. Parat has been calling the director of HCI in person, right? Over and over again. We've been talking to them. We've been pushing and pushing, but it's like pushing a rope, and they're bureaucrats, right? They don't know anything about Aliso Canyon, or it's like, you're at this place in the line and this is when you get your data. And right now the state budget is in such a crisis that they're not restaffing positions. And there's nothing we could do. We could, pound our fists on the desk all we want. The bodies aren't there in the desk to do the job.
Ready for your patience. This is what I wanted to get to you. I'm moving it along. Thanks for your patience. I know we had Yael and we had Gary, and we probably could wrap it up because we're a little bit over what we were supposed to say.
I want to thank you all for the work that you have done. I was kind of surprised that you mentioned that there were no soil samples ever taken, and they continue to build in the area, and there needs to be soil samples, or we're going to have new families with new little kids. Sorry. Who are going to be damaged. And that's really important to me, that we take care of that. And if we get good data from you, then we can go and give help to the county, because we'll have this good data to show them. I know you guys don't want to be political, but it's ridiculous that it's 10 years. Thank you.
Thank you.
Mine is missed, so I can't get my mic to work.
Here, Mike.
I apologize. I haven't worked with the soil data. That's not to say that the soil samples haven't been taken. I'm not aware of them. But I haven't worked with them personally. So don't mistake my ignorance for, that there's a lack of anything going on, but I'll defer to Mike about what might or might not have.
Yeah, well, I mean, there were some soil samples taken right at the wellhead, but there's not been an extensive analysis done of the soil contamination. When we proposed a study, we had to choose what we thought was the most likely path for intake of the contaminants. And, given that it was largely an air pollution event, it is possible that some of what came out with those well kill fluids landed on the soil and then has become re-entrained and brought into residential areas. But we still don't think that that would be the major source of exposure. The major route of exposure that we've been concentrating on is the air exposures.
Thank you. And thanks for your patience. And Gary, thanks for your patience as well. You're up. I have your written comments, so I'm assuming what you want to say is the same, but let me know if you want me to read them.
Well, something else. My name is Gary Fordyce. And one of your things put on the screen, it was stated that the gases went to the south. What I viewed slightly to the south and then extensively to the southeast. And yet you stopped the information when you presented the zip codes at 91325. Where's 91343? Where's Van Nuys? Where's, I think that's 406 or something. What about the rest of it? Because it was going southeast. And so that's my question, and then I'm going to make a statement.
But we do have in our impact zone many areas that are to the southeast. And that's, we're not adjusting it for the plume shape yet. The remote sensing gives us a lot more information on that. And what we've seen so far from those retrievals is that most of it is going, due south more than southeast. That's not to say there weren't days where there weren't satellites or aircraft flying that it could have gone to the southeast, but we're basing it on the best information that we can glean. But we do have a lot of areas to the southeast that are included in the impact zone.
Well, when I say southeast, I saw central LA and what appeared to be even, I'm not sure of that, I can't remember the name of that facility, but it was like perhaps up toward the San Tonga area. It covered a lot of the East Valley, it would seem.
Yeah, that was just a map. So we were trying to show the regional dimensions of different pollutants and to make the point that LA has got a lot of other sources of pollution that could be contributing to exposures. So we can benchmark that and look at it in our control communities. And
people should be considered for any health impact as well.
Well, they might be getting health impacts, but we don't have evidence that they're getting health impacts from this leak disaster.
Because you seem to have stopped at 91325.
Yeah, I'm sorry, I don't know the zip codes around.
Well, you had them, I took a photo of it. 91325 is where you stopped. And then right next to it is 91343. And so on.
Okay.
You're getting closer there. Go back one or two more.
So these are back.
There you go. And you
So-
see the 405 freeway there. And the plume started going southeast and those areas southeast of 91325 were ignored.
Yeah, I mean, we don't have a lot of evidence that it did. Based on what we see from the satellite retrieval and from the chemical transport models. We think that this is capturing the bulk of the area.
Yeah, that's the 5 miles radius. That covers like more than 83% of the complaint.
Well, I understand your 5 mile and I understand, but when you showed the photo of the dispersion of the gases, it got wider and wider and more. And it was all going to the southeast, it seemed. And maybe it should have been more than 5 miles. So I'd like you to consider it. And
Yes.
there's nothing more. I think we can argue back and forth on this right now, but I do want to make a statement. First, I commend all of you. And I mean that sincerely for everything you've done. And no matter what I say, it will not nullify what I just said. But in the medical profession, one thing I've heard over and over and over again is time is life. Well, how much time has gone by and how many people have perhaps paid the ultimate price and we're still not getting anywhere? Now, the reason I bring all this up is what LA County has determined is pure nonsense. When you consider, by example, asbestosis, which there was things in my profession that exposed me to that. And I believe I heard all these statistics. It takes 10, 20 more years before it impacts your health and it could take your life. Now, when you consider how long it takes for something like that to impact someone's health, and LA County says, oh, that crisis is over, it has no meaning anymore. Wait a minute. What about the long-term impact? The people, the victims of this event, the doctors who are going to treat them. And doctors are like scratching their head and say, well, I know you've got this, but I don't know what's causing it. Well, obviously, there needs to be more information. Now, in my opinion, and I have no trust and no faith in LA County, this is a tantamount to a military tactical maneuver. We're going to protect our liability. We're going to protect the gas company. We're going to protect Los Angeles. We're going to protect LA County. We're not going to expose ourselves to any liability of any kind. Now, I think it's a travesty that that's the way it could end up. Now, again, I commend all of you, but isn't it going to be a sad case if in January 2026, they put an end to this and the information that is really needed for the people, and you heard it from many people here tonight. I'm just echoing all of this stuff. For it to end up that information that is so dearly needed, the ultimate information of what is it that we were exposed to, what is it that is causing our problems, and the chemical contents of everything that they won't release. It's getting more difficult to try to explain this, but if this ends up that tactical maneuver wins out, and looking back in history, what this country has done to so many things, the cover up of Agent Orange for Vietnam veterans like myself. They didn't admit anything for, I don't know, it seemed like 20 years. Well, how many have died before they admitted it? Well, they limited their liability. There's so many things that this country practices in stall tactics, in evasion, and so on. So in the end, if that's the end result of this, as the pattern of this country treats these calamities to humanity, as much as I commend you, people will probably look back and say, well, that was a brief interlude in entertainment. In the end, we're all dying, we're all suffering, or a combination of both. And even though you're commended, does this end up as a brief interlude in entertainment? I don't know how to say that in a better way, but I hope you understand. I'm not demeaning any of you. I'm commending you. But please, fight like hell, finish this thing. I know you don't want to be involved in politics and all that. Do it anyway. Or get people that back you up and let them do the fighting. But work together somehow. Thank you for listening.
Thanks. I realize that this map, even though we review these over and over again and we think they're clear, I realize that this could have produced confusion because it says produced a benzene peak. So it was meant to illustrate that there's the peak of benzene during the event. Oh, sorry. Yeah. So it was meant to show that there was this peak here against the background levels that we observe in Los Angeles. So the point was that there are other sources of benzene throughout the region that elevate levels, not as high as what we saw here, but on an ongoing basis, they elevate them quite a bit. So I apologize that that wasn't well titled because it makes it look like the whole blowout period. The blowout did not influence these areas down here. It's largely in our impact zone, show them as this little half circle. Yeah.
Person with a raised hand, and I did want to get back to the people that had questions on the first one. So let me just get to this online question. Helen, go ahead and unmute.
Hi, thank you for giving me the chance. I don't have a questions, I just have a comment. I agree with the gentleman who said our main enemy was the health department. I find that out the first few months that I got involved. I'm one of the activists that has been fighting this thing for the last 10 years. I honestly, listening to you guys, feel like some of you want to do the right thing and are there to understand what's going on. But on the other hand, I feel like you guys are too late to this game. You missed a lot of community talks, interactions and hurt, and when people were talking about how sick they are, how awful we feel. You missed all that. And you came to the game very, very late. And even though you want to do the right thing, you don't have the right information at this point. You don't have enough information. The best thing would have been actually go and talk to the people, or I don't know. From the beginning, I said this money is going to be wasted. All the information you are giving us at this point of your study, we already knew. We already had this information. We already had done our own study, and we know how we feel. We know if you talk to people in the room, everybody has at least one person with that cancer diagnosis. We know what we went through. We know how we feel. You guys don't know that because you are not really communicating with the right people. My own daughter is a scientist. I know how the scientists work, and I appreciate that you want to do the right thing, but this hasn't been the right way of doing it, in my opinion. And I know with budget cut and everything, I know what's going on in the science and research area, and I'm sad to know that's going on. But honestly, this is not I feel like the money's been wasted. I don't want to insult anybody on this panel, and it's nothing personal, but all the information you're giving us, we have that information and more, only if you would listen to the community. That's all I wanted to say, and thank you for your time, and thank you for, but please, if you want to continue, look in the right place. I know how valuable your time is, and I know how this community is looking into you, but it's very disappointing at this point. Thank you.
Yeah, if I could just respond briefly, I was here measuring pollution, putting my own health at risk in December 2015. I was here every second day for months. So, you may not know that. You may not also know that we worked very hard with the community to try to put together a National Institutes of Health grant. And to do that, we needed to have a level of alignment of all the community interests, and we couldn't get it. There was not agreement in the community. And we thought if we go, and we had successfully competed for other grants like this from the Air Resources Board and from NIEHS, some of which led to statewide programs like AB 617, community monitoring. Part of the reason that you're getting monitoring here is from the work that we did. So I'm sorry that you feel that way, but I don't think that you have got the facts correct.
No, Dr. Judd, I remember you in the meetings, actually. I remember you, but not everybody else on that panel. And I feel like there's a miscommunication or lack of communication, not miscommunication. Even between, I mean, some of you don't even, I feel like you're not familiar with the community and what we went through. I mean, just studying the doctors and clinics around here and compare it with other areas, I was relocated and I would never come back to this area, go to the doctor. I wouldn't want to be affected again. All my doctor visits and everything was in some other area. And a lot of people, my own friends, have moved away and some people have been died since then. I mean, this research you guys are doing right now, the numbers you're giving is not accurate. The comparison you're doing is not accurate. You're not doing research on the community members. You're just going through the area, and we have all new, I mean, have you gone to see where people have actually moved away and get their results?
Yeah, I mean, we've tried. We're in the process of doing this mobility analysis, so we'll know who moved away. And I know that's a big concern.
I
that
know I've
people that
never been
were very
contacted.
sick moved away.
I know I haven't been contacted by anybody. I mean, I'm one of the community members. How do you get hold of these people? And do you have all the information for all the people, community members who moved away?
No, we don't have that, but
Okay.
we do have all the information for people that were born here. So that's the other thing. I mean, I think you could look at this and say, yes, we wish it had more results, but you have a very solid result on adverse birth outcomes. And we know that based on the fetal origins of disease hypothesis, that a lot of those adverse birth outcomes will translate into future chronic diseases in adulthood. You have now a very solid analysis showing that there was significantly and substantially elevated levels of emergency room consultations. We have a focus group that was done by people that are experts in medical anthropology and sociology that is specifically meant to give voice to the concerns that you're raising. And we have engaged extensively with the community through our community consultation network and for these meetings and through many offline conversations. So, I guess we could look at it as it's half, cup half full, cup half
Yes.
empty.
But have you communicated all that with the Department of Health, who kept telling us that, oh, these are only safe levels, you guys are okay, there's nothing going on? They kept telling us that, and they stopped us from being tested. Dr. Rangan did with his letter to all the doctors and communities. Have you been communicating with them? And where is their apology? Where are they right now? What are they doing about it right now?
Then I want to get back to
We
the-
give them regular formalized updates to them and to our scientific oversight committee.
No, they don't care like as usual. Thank you.
Thank you. Appreciate it. As promised, I wanted to get back to people who had questions on the first presentation and we didn't have a chance. So I had Craig, Matt, Nisam, and Gary had a written comment. So do you guys still want, thanks for staying so late. Do you want to ask the questions that you had on the emergency department visit study?
I would stay.
I'm happy. I know, but you have to contract to have this facility later next time. But everybody's willing to stay, so, and I promise. Okay, thank you. Craig?
Yeah, I did have a follow-up question on the, thank you. So, because there seems to be a lot of underlying agendas, so I'll be straight with what my agenda concern is and the data that I saw. So let's start with, I want to make sure that nothing is diluted in your findings. So I got my radar went up when I saw the expected, and if we can go back to that slide where it does expected valuation of ED visits, that seemed illogical to me from the bit of data that I did see, and granted, I'm basing it on a visual observation. So let's see, keep going back. This one. Okay, Dr. Jared, you said you're going to, the expected impact, the expected result to the impact zone was that hash line, right? And I get it. And by the way, thank you for giving me the quasi-experimental design, which is the change on change study analysis that I've been doing in business for 25 years. So thank you. Now I have a proper terminology for it. I call it change on change. So change on change. You look at before, they're not that far apart. They have a similar sort of cadence to them on the before graphs, control versus impact. So you would see, and the delta between the two is rather narrow, rather minor. So if you did an expected impact, you would do a delta between the impact zone and the comparison zone on the before. So whatever that delta is, let's say it's, one given data point there, it's 7%. You would do 7% greater on the during. So I don't understand how your expected is so much higher than what it is in before if you're using the before as your model. Dr. Jared's had enough. Thank you, sir. We do appreciate your professionalism at all times. With all due respect, sir. Okay, thank you.
So there are different methodologies that can be used for this kind of analysis. So if you recall the birth outcome data, what they did look at the prior pattern. So the before period, their periods are a little bit different because we're analyzing different data, but they looked at the prior period and then they trended forward. So what would it look like in the future? So that's what you're describing, that kind of analysis. This is different. What we did is we are looking actually at what the data show us. We're not predicting what the rate is going to be per se, but we're looking at before, what was the pattern of utilization? During the time period, what's the pattern of utilization? The model, if I can get technical, is you're looking at, if you are looking at these rates, you have an indicator for the impact zone community, you have an indicator for the comparison community, and then you're looking at the month by month change, right? So the model would then look at the rates and report it. This is the rate for each population in this month. Then what we did is we looked to see, we added an interaction term, and that allows you to see if the patterns are different, okay? If you don't put an interaction term in the model, it only measures the distance between these patterns. What we do is we add so that expected that you see is if you don't account for the fact that the pattern could actually be different. Am I making sense?
Yeah.
Please.
Help me understand, what are you going to say to the peer reviewer who said,
Thank you.
explain to me why is the spread between the expected and the background, is that different from the spread between the community and the background on the year before, which you are using as a control year? I see that the model comes out with that. It needs an explanation.
Yes, absolutely. So in the quasi-experimental design, you look at the pattern before, you then look at what happened afterwards. And so what you see is the difference, you're seeing an actual difference in the two time periods. In this case, you're seeing a huge spike in February. So that's as far as the model goes. The rest of it is interpretation of the data. What is different between the two communities is what they were exposed to. One community is exposed to the blowout, the other one is not exposed to the blowout. So you conclude that the community that is experiencing this spike in utilization is because of the exposure.
Expected impact zone, is that the expected background without Aliso's impact? Is that what we're interpreting here?
yeah, the theory is that if it was no, if the two communities had the same exposure, that's what you would expect to see.
You saw me with me, and I'm just doing in the visualization here. Let's say on the before, the delta between the two is 6%. Your expected looks to be, 25 or 30% greater. And that's just illogical unless I just don't, you haven't explained how the model draws that expected curve. Because to Esam's point, what others are going to interpret, and certainly the gas company, is, oh, it wasn't that bad. Look at how this model showed how expected it was. It's just slightly above what was expected. When that's, I do not see how you go from before with the small deltas between control and test group to the big differences. You saw me with me on this?
Okay, so the expected here is for illustration purposes.
How's it going to be used, to his point? To me, this is dilution. Yeah, why do you need it? Why can't you just say, oh shit, ED visits were 6.5 times higher
Yes,
than they were to the control group?
that's what we were going to say.
Okay,
Exactly.
then drop the expected, because the expected is a dampening factor that is going to be misused.
I appreciate your comment. I do agree with you. This was for illustration purposes. I'm sorry that it is giving an impression which is not really what we intended.
Okay.
By the way, we are also not, we are looking at, in this slides, we're looking at the average before and after. There is no expected here. These are the analyses that are presented in the paper as well. And then we also did a month by month comparison, which I'm not showing here. It's just too much data. It gets very confusing.
This
And
is
so
on average during those periods.
This is an average over
Well,
on those
go back-
periods. So this tells you
Go
that,
back a slide and we can see where the peak was. We just visualize it.
right.
Yeah, so it just happens to coincide with February, which probably driven by flu or something like that. But the delta is the strongest there. most
Right.
likely. Okay.
So we look at the overall and you see that the numbers are different. We did this analysis just to make sure that flu.
Yeah.
Here you see a spike even among people with presenting to the emergency department with flu. There are more ED visits in the Aliso Canyon community in this exposed community.
Got it.
Okay, so that means that people probably had exaggerated symptoms
Correct.
because of the exposure.
Easy conclusion.
That's the reason we did all of this
I understand.
additional analysis.
I liked what you did, everything you did. I like this significance here noted. I do not like the expected, because I think the
Fair
model is wrong. It has to be, based upon the little bit I've seen. And I think it's going to be completely misused by those that are going to advocate for the continued operation of the facility.
Thank you.
Thank you.
Gary, did you have anything on that first one? Okay, go ahead. Christina, can we get Gary a mic? And then after that, we will close it out.
Okay, I believe what I wrote was doing to try to understand what direction and what intensity the transmission went. And as we've seen by the picture, it went south and then turned to the southeast primarily. What I wrote down was you did the previous picture, that format. You did it for the overall. There we are. What we just looked at was considering observed in impact zone, expected in the impact zone, and observed in comparison community. We just looked at that chart. Please relate these to zip code by zip code, indicating intensity and ultimately direction of pollutant transmission. Now, when I spoke previously, I was concerned that the photo indicated everything went to the southeast. Here I'm this might be an alternative way, since you did not go beyond zip code 91325. If we had that same study, which you focused around the blowout, if you took that zip code by zip code, then we could see how the numbers change and how close and when they start dropping off. And maybe we wouldn't be so concerned how far those of us who are southeast are impacted, because we'd see you start with high numbers here and then they change over different zip codes. And that might also indicate to you how you might realize in hindsight, maybe you should extend it into other zip codes. Does that make sense to you?
It does make sense. And we actually are planning to look at what is sort of zip code by zip code getting further away. So that's one of the analysis that we're pursuing, to see whether let's just take the ED visit example. There are more ED visits closer to the well, and then as you go further away, the numbers go lower. Our restriction is that we have to look at it by zip code. It's a pretty big area, a zip code, right? So the analysis.
Yeah, but when you show that plume going all the way into central
Yes.
LA and stopping it at 91325, it skips a whole lot of territory with data.
It didn't go that far.
Well, the picture said it did.
No, he said it's measured that benzene in that area. Coming from other sources.
I apologize. I probably didn't present something as clearly as I could have. Dr. Jarrett tried to clean it up for me, but just to repeat again, when I showed the benzene plume for the whole region, this is the one that I think generated the confusion. The way that air pollution works, something doesn't ever get reconcentrated. Once it dilutes away, nothing will ever like reconcentrate it again. It's a thermodynamic principle. And entropy only works one way. So basically, when you see that sort of darker area or the higher concentration over central Los Angeles, those are other sources. Those are not the Aliso Canyon blowout emissions. The Aliso Canyon blowout emissions are here in the semicircle, and they get diluted as they move downwind. Nothing in the atmosphere would reconcentrate them. So I just didn't explain that clearly enough. I apologize for all the confusion, but that's
That's from other sources. Or is it?
so when I titled this that Aliso Canyon produced a peak, I was referring specifically to this light, spot indicating the high concentrations around the impact community. There's a peak there that wouldn't have been there had the blowout not occurred. That was all that I was trying to imply with that title. The downtown LA, if I would simulate that for the 5 months in 2016 and 17 or 2018 and 19, all this junk would still be there.
So we're back to what I'm saying about zip code by zip code. And this isn't just the benzene, there was the methane, and what was the third item? Again, what direction were they traveling?
The atmosphere moves everything together. The air blows and it carries things along like a river. It doesn't,
Well, yes.
one doesn't go upstream, one goes downstream. Everything gets carried along together. So the only thing that changes is that some things react faster than others. So some will decay faster along that path that they're all traveling together faster than others. But
Okay, but our gentleman here said like the one item is 1% is too much, and yet you didn't start measuring it until 10%. And here this is all traveling, and maybe you can say, well, it wasn't concentrated, but on the other hand, maybe it was too much because it was 1% already. And there's, what are we breathing?
all of those things are in the calculation, even though the colors fade as the concentrations drop off. It doesn't mean that we assume that they're zero. We have a number to go with each of those things, and the color scale, if I would change it, would show that that plume is still there, and it will be in the exposure data that gets used for the health data. Health Study. So we're not ignoring any of those things. And if you want to expand to communities further south or to the southeast, to those other zip codes, the data is ready for that. That all of the data that we're providing could be used that way. The team has to decide whether that makes sense or not from a statistical point of view, but the exposure data is there.
Okay, so if I am hearing you and I dismiss what I'm visually seeing as these plumes and travel to the southeast and so on, I still feel like going back to the zip code by zip code by zip code, and we see the progression and the intensity of toxins that, and how they either increase or diminish along the path, then maybe those of us out here who are not doctors like yourself, will have a better visual understanding of where we stand.
And that can absolutely be done. So I think, thank you for the feedback and the idea, and the data is ready to do it. I didn't have time to put all the figures in that maybe I didn't anticipate all the questions that would come up, but we can certainly do that.
Thank you.
Thank you, everybody. Dr. You're gonna answer this question and close us out for the night. And if everybody does have a chance to fill out this form, if you're too tired, could just scan the code and do it later so that we can make these meetings really,
Yeah,
fit your
I was
needs.
just going to mention that we have pursued that. It's called a distance decay gradient study. And we did that in the birth outcome paper. So it does show that the effects get smaller as you go away from the leak. And by about 15 kilometers, there's nothing. So yeah, so I was just saying, we have done that analysis for the birth outcome study where we've looked at how it declines as it gets further away. And we do see that pattern where the risks are the highest closest to the well head. And then as we get farther away by about 15 kilometers or around, 10-ish miles, we don't see any effects after that. So we can do that with this analysis as well. And we will. So thank you for that comment. Well, I want to thank everybody for all your time and, all the meetings you've come out to, and we really do appreciate your input. And I understand the frustrations, and, if we could go any faster, we would, but we can't make data and analysis just appear. It takes a lot of time, and, that's one of the reasons that we have credibility is because we don't put things out willy-nilly. We put them out when we are really ready to stand behind the results. And what you're seeing here is clearly a work in progress, but we're at the point where we felt like there's enough there that we can show you. And I think we have to do a better job explaining that expected curve, because I see your point exactly, Craig. So we'll do that, and we'll do an update, and we can either discuss that offline or we can put out a brief on it to explain it, because a lot of these analyses are going to use the same framework for the health studies. And so we'll get more clarification on that for you. Okay. So thank you again.